Right now, inside your body, an organ system could be operating at barely 30% of its normal capacity.
Yeah, or even less, honestly.
Right? It could be actively failing. And yet, your brain is receiving absolutely zero pain signals. You feel completely, entirely fine.
So you wouldn't know a thing.
Exactly.
Yeah.
You might go to the gym, eat a heavy dinner, sleep through the night, and wake up totally unaware that a biological cliff is just, approaching.
It's terrifying when you really think about it.
It really is. So welcome to the Deep Dive. We are so glad you're here with us today because, well, if you're listening to this, you're likely trying to cut through the absolute avalanche of medical information out there.
Oh, the noise is just deafening these days.
Yeah, you want clear, actionable insights about your health and your body without feeling completely overwhelmed by clinical jargon or, frankly, worse, predatory misinformation.
Which is an incredibly difficult objective in the modern digital age. I mean, the signal-to-noise ratio when you search for health information is arguably at an all-time low,
Yeah.
making it profoundly difficult to navigate conditions that don't, announce themselves with obvious acute symptoms.
And that brings us to our mission for this deep dive. Today's source material centers around a crucial concept titled the silent struggle, recognizing early signs of kidney disease.
A very apt title, honestly.
Right. We're going to explore what the symptoms of progressive kidney disease actually are, why they're notoriously difficult to spot, and the sheer biological mechanics of why early chronic kidney disease operates in such, stealth mode.
And it's important to note, our source material also provides a really fascinating meta layer to this whole discussion.
Oh, definitely.
It brings us into the world of the iMedix platform, which operates as an independent medical information ecosystem.
So we're exploring not just the biological struggle of the disease itself, but the broader, everyday struggle that patients face.
Yeah.
Trying to find reliable patient education, decode medication safety warnings, and formulate complex treatment questions for their doctors.
Yeah, the real-world application of all this knowledge.
Okay, let's unpack this. Starting with the central premise of our text, the silent struggle. I want to zero in on that specific phrasing.
The word silent.
Yeah, exactly. When we talk about a disease being silent, it implies a progression happening entirely beneath the surface. It goes back to that terrifying scenario I mentioned at the top of the show, operating at 30% capacity with no alarms going off.
Well, the silence is fundamentally a byproduct of human evolution and, the incredible, almost stubborn resilience of the renal system.
Stubborn resilience, I like that.
To understand the silence, we have to look at the architecture. You have two kidneys, and each one is packed with roughly 1 million microscopic filtering units called nephrons.
Wait, 1 million in each?
Roughly 1 million, yeah. And to give you a sense of scale, these nephrons are filtering about 200 quarts of fluid every single day.
200 quarts? That's a massive amount of volume.
It's huge.
Yeah.
And the silence of chronic kidney disease comes from a biological phenomenon known as hyperfiltration.
Okay, let me see if I have the mechanics of hyperfiltration right, because I've always pictured it like a factory floor.
Okay, a factory. Let's hear it.
So if you have a factory with 1,000 workers on an assembly line, and 200 of them get sick and go home, the remaining 800 workers don't just, let the conveyor belt pile up.
Right, they compensate.
Yeah, they drink more coffee, they speed up their movement, they work overtime to hit the same production quota. So the factory manager, which I guess is your conscious brain in this analogy, looks at the daily output numbers and thinks everything is running perfectly.
That analogy gets you halfway there.
Yeah.
But what it misses is the physical toll of that overtime.
The burnout.
Exactly. In the kidney, those remaining workers, the healthy nephrons, they aren't just moving faster, they are physically altering their own structure.
Wait, really? Physically altering?
Yeah. The blood vessels leading into the nephron literally dilate to let more blood in, increasing the intraglomerular pressure. It's like attaching a fire hose to a garden sprinkler.
Oh, wow. That sounds damaging.
It is. The nephron stretches, it actually enlarges to handle the massive increase in flow.
And I imagine biological tissue can only stretch so far before it sustains, structural damage.
Precisely the issue. That constant high pressure creates sheer stress on the endothelial cells lining the filters. Over months and years, that mechanical stress causes inflammation, which eventually leads to sclerosis.
Which is scarring, right?
Exactly, scarring. The healthy nephrons, basically work themselves to death trying to compensate for the dead ones.
Wow.
And as they scar and die off, the burden shifts to an even smaller pool of remaining nephrons, which then have to hyperfiltrate even more. It is a vicious compounding cycle.
So they compensate so brilliantly that your overall kidney function can drop significantly before the quote-unquote factory output drops enough for you to feel it.
That's the silent part.
Which sets up the paradox our source material explicitly focuses on, right? Recognizing early signs. I mean, how on earth do you recognize a sign of something that is actively hiding its own failure from you?
It's a huge challenge.
It requires a total shift from passive observation, like waiting to feel a sharp pain before going to the doctor, to an active, almost investigative vigilance.
Well, active vigilance is the only way forward. Passive observation relies heavily on nociceptors, which are, pain receptors.
Okay.
If you touch a hot stove, the feedback loop is immediate and agonizing. You pull your hand back.
Yeah, thankful.
But the renal parenchyma, the functional tissue of the kidney, it lacks those pain receptors. There is no nerve ending in the nephron capable of sending a, hey, we are failing signal to your brain.
So the early signs we're talking about aren't like localized pain in your lower back.
No, usually not. They are subtle systemic changes that occur when the compensation mechanisms finally start to crack.
I think about the psychological dissonance of that. I mean, how does a patient wrap their mind around being genuinely unwell, potentially facing a life-altering chronic illness, when they wake up, look in the mirror, and feel fine?
It's incredibly jarring for patients.
It completely shifts the burden of health. You can't just react to your body anymore. You have to proactively seek out laboratory testing and actually understand clinical data.
Yeah, you have to be your own advocate.
It's like having a slow leak in a car tire. You don't hear a pop, you don't feel a blowout at 70 miles an hour, but day by day, the pressure drops. And if you aren't manually checking the gauge, you won't know there's a structural problem until you're, driving on the rim.
The tire leak is a solid visual. Though, in the context of the human body, driving on the rim equates to end-stage renal disease, where you're looking at dialysis or a transplant.
Right, which we obviously want to avoid.
Absolutely. We want to catch the slow leak. And the signs of that slow leak, when they do start to manifest, fall into a few distinct, often misunderstood categories.
Okay, let's go through them.
The first major one is fluid retention, medically known as edema.
Because the kidneys are essentially the body's master plumbers, right? They regulate the balance of water and sodium. So if the plumbing backs up, that fluid has to go somewhere in the tissues.
Exactly. It's a matter of both hydrostatic and oncotic pressure. When the kidneys lose their ability to efficiently excrete excess sodium, water just, follows that sodium, increasing the total volume of fluid in your vascular system.
Like a hose that's too full.
Right. And this increased pressure pushes fluid out of the blood vessels and into the surrounding interstitial tissues. Because of gravity, this most commonly manifests in the lower extremities.
So we're looking for swelling in the feet, ankles, and legs.
Yeah.
But again, these are things that are so incredibly easy to dismiss. You might notice your shoes feeling unusually tight at 5 o'clock, or you take off your socks and see those deep red indentations in your skin that just don't bounce back quickly.
Very common, early signs.
But most people just think, oh, I was standing on my feet all day, or
Yeah.
I had really salty takeout for lunch.
Or it can appear as periorbital edema, puffiness around the eyes, particularly right after waking up in the morning.
Oh, because you're lying down.
Exactly. When you're lying flat, gravity isn't pulling the fluid to your ankles, so it settles in the loose tissue around the eyes. And you're absolutely right about how dismissible it is. People blame poor sleep or allergies all the time.
Speaking of poor sleep, that leads right into the second massive symptom category.
Yeah.
The source highlights fatigue. But we need to make a really clear distinction here for you listening. We aren't talking about the 3 o'clock slump where you need a shot of espresso.
No, not at all.
This is a profound cellular level exhaustion, right?
Yeah, the mechanism behind renal fatigue is multi-layered. But the primary driver is actually often anemia.
Anemia from kidney failure.
Yeah, we usually think of the kidneys strictly as filters, but they're also part of the endocrine system. They produce a hormone called erythropoietin, or EPO for short.
EPO is the signal that tells the bone marrow to manufacture red blood cells, right?
Exactly its function. The kidneys are constantly monitoring the oxygen levels in your blood. If oxygen is low, they secrete EPO, which travels to the bone marrow and stimulates the production of reticulocytes, which then mature into red blood cells.
Okay, I follow.
But as the renal tissue becomes scarred and damaged through that hyperfiltration cycle we discussed, the specialized cells that produce EPO simply die off. Production plummets.
So your bone marrow just stops making enough red blood cells,
Precisely.
which means your blood literally loses its physical capacity to carry oxygen to your brain and your muscles. You could be breathing perfectly fine, but your tissues are suffocating on a cellular level.
That's a great way to put it. And then add to that the buildup of uremic toxins.
Uremic toxins.
Yeah. When the glomeruli, the actual filter structures within the nephrons fail, metabolic waste products that should be excreted in the urine start accumulating in the bloodstream. This is called uremia.
That sounds bad.
It is. These toxins can actually cross the blood-brain barrier. They interfere with central nervous system function. So you have a brain that is simultaneously starved of oxygen and bathed in metabolic waste. The result is this bone-weary cognitive fog and physical exhaustion that no amount of sleep will fix.
That sounds absolutely bleak. You're carrying around heavy extra fluid weight, your blood can't carry oxygen, and you're being slowly poisoned by your own metabolism.
It's a heavy burden on the body.
And doesn't that toxin buildup lead to other bizarre systemic signs? Like I've read about patients reporting a strange metallic taste in their mouth or even ammonia-smelling breath.
Yes, that's a direct result of the uremia. High levels of urea in the blood are broken down into ammonia in the saliva,
Oh, wow.
which leads to that metallic taste and what clinicians call uremic fetor, that distinct ammonia breath.
Wow.
But perhaps one of the most maddening subtle signs of toxin buildup is uremic pruritus, which is severe itching.
Right, but this isn't like a mosquito bite or dry winter skin. From what I understand, it's a deep internal itch that topical lotions do absolutely nothing to soothe.
Nothing at all.
What is the biological mechanism there? Are the toxins irritating the nerves directly?
It's a combination of factors, really. Part of it is peripheral neuropathy. The uremic toxins physically damaging the nerve endings in the skin, causing them to misfire and send constant itch signals to the brain.
That sounds like torture.
It is. But it's also tied to the severe electrolyte imbalances that happen as the kidneys fail, specifically calcium and phosphorus.
Okay, let's hover on those electrolytes. The source material emphasizes that kidneys maintain this incredibly delicate balance of sodium, calcium, phosphorus, and potassium. What happens to that balance when the hyperfiltration eventually fails?
Well, normally the kidneys excrete excess phosphorus. When they can't do that anymore, phosphorus levels in the blood start to rise.
Okay.
To balance this out, your body releases a hormone that literally pulls calcium out of your bones and into your bloodstream.
Wait, it steals calcium from your skeleton.
It does. Which not only weakens your bones over time, but the excess calcium and phosphorus can bind together in the blood to form microscopic crystals.
Oh, no.
Yeah. And these crystals can deposit in the skin tissues, causing intense, unrelenting inflammation and itching.
So your body is essentially creating microscopic sand under your skin.
Pretty much.
That is horrifying. And what about urinary changes? If the entire organ is designed to produce urine, I have to assume what happens in the bathroom is a massive indicator of the silent struggle breaking the surface.
It definitely is. But the changes can actually be kind of counterintuitive.
Really? How so?
Early on, people might find they need to urinate much more frequently, particularly in the middle of the night. It's a condition called nocturia.
Wait, if the kidneys are failing, shouldn't you be producing less urine? Why would you pee more?
It's because of where the damage is occurring in the nephron. After the initial filter, the fluid travels through a long, complex structure called the tubule, specifically the loop of Henle. This is where the kidney concentrates the urine by reabsorbing water back into the body. Early kidney damage often impairs this concentrating ability.
Oh, I see.
So the kidneys are still filtering fluid, but they can't concentrate it. You produce larger volumes of dilute urine, which forces you up 3 times a night.
That is fascinating. It's like the filter works, but the recycler is broken.
Exactly.
And what about the appearance of the urine? I know protein in the urine is a massive red flag.
Yes, proteinuria. The glomerulus is a remarkably selective filter. It acts like a microscopic sieve. It lets tiny waste molecules and water pass through, but it is supposed to hold back large essential structures like red blood cells and protein molecules, specifically albumin.
Okay.
The cells that wrap around the capillaries in the glomerulus, called podocytes, they interlock their foot processes to create this barrier.
But when that high-pressure hyperfiltration damages those podocytes, the sieve gets stretched out, the holes get bigger.
Exactly. The foot processes efface or flatten out, and the barrier breaks down. Albumin starts leaking right into the urine.
And the physical manifestation of this is, what, foamy urine?
Consistently foamy urine. And we aren't talking about a few bubbles from the velocity of the stream hitting the water. We're talking about dense, white foam that looks like the head of a poorly poured beer.
Wow.
And it doesn't dissipate when you flush.
Foamy urine. That's one of those things where if you don't possess the specific vocabulary and biological context, you would never in a million years connect it to a failing organ.
No.
You would absolutely just think there is leftover cleaning product in the toilet bowl.
Most people do.
And that realization transitions us so cleanly to the meta layer of our source material. Because to check that tire pressure gauge, to recognize the foamy urine, the edema, the nocturia, you need reliable, accessible information. The sheer invisibility of these biological symptoms forces patients into the digital realm to find answers.
What's fascinating here is how that exposes them to a completely different kind of toxicity, right? Misinformation and data obfuscation.
Precisely. Let's talk about the flaws of the current medical research system. When you experience these vague symptoms, fatigue, a weird itch, swollen ankles, and you type them into a standard search engine, you are met with an ecosystem designed to monetize your anxiety.
It really is.
You have search engine optimization spam, where content mills churn out generic articles that rank highly just to serve you display ads.
And increasingly, we're seeing the rise of AI hallucinations in search results.
Oh, don't get me started.
I mean, a generative algorithm might scrape outdated forms and present a highly authoritative-sounding summary, suggesting that your foamy urine can be cured by a specific herbal detox tea.
Which is so dangerous.
Right, because the algorithm doesn't know biology. It only knows predicting the next word in a sentence based on training data.
Not to mention pharmaceutical marketing heavily disguised as patient education. I read an article the other day about managing mild hypertension, and halfway through I realized the entire piece was subtly framing a specific branded medication as the only modern solution.
Yep, seen that 1,000 times.
It completely glossed over dietary interventions or generic alternatives. It is cognitively exhausting to play detective with your own health information.
Which is why the source material explicitly defines iMedix as an independent medical information platform. In the modern healthcare landscape, that word independent represents a structural architecture, not just a buzzword.
Right.
It means the database is untethered from pharmaceutical sales funnels or, hospital network patient acquisition metrics.
It's neutral ground. It's the difference between a search engine algorithm prioritizing engagement and a database architecture prioritizing factual relationships.
Exactly.
And according to our source material, this kind of independent platform builds its architecture on 3 critical pillars: patient education, treatment questions, and medication safety. Let's look at how these 3 aren't just isolated features, but a continuous loop of empowerment for the patient.
Well, if we connect this to the bigger picture, the foundational pillar is patient education. But we need to define what good education actually looks like.
Yeah, it's not just a WebMD list of symptoms.
Exactly. It isn't just handing a patient a medical dictionary. It is providing the biological narrative. If a lab report simply says albuminuria detected, the patient just feels fear.
Understandably.
But if the educational platform explains the anatomy of the podocytes we just discussed and explains why the albumin is leaking, the patient gains comprehension. Fear paralyzes. Comprehension mobilizes.
I love that. And that comprehension allows the patient to move to the second pillar, treatment questions. An empowered patient uses that vocabulary to formulate specific, nuanced inquiries. But I want to introduce some friction here because I can hear listeners pushing back.
Okay, let's hear it.
Here's where it gets really interesting, but also a bit overwhelming. Isn't handling the diagnostic and treatment questions solely the physician's job?
Not entirely, no.
Let's be honest. We all know the stereotype of the patient who comes into a clinic wielding a stack of printouts from the internet, essentially demanding the doctor run a dozen obscure tests. Does arming the patient with complex treatment questions actually help? Or does it just create an adversarial dynamic in a rushed 15-minute appointment?
That friction is incredibly common, but It stems from a misunderstanding of what a structured treatment question actually is.
Okay, clarify that for us.
The internet printout stereotype usually involves a patient who has fallen down a rabbit hole of rare diseases and is presenting the doctor with noise. A platform like iMedix is designed to help patients filter the noise and present signal.
So it's the difference between saying, I read online that I might have heavy metal poisoning, versus presenting organized data.
Exactly. Physicians are operating under severe time constraints. If you walk in and vaguely complain of being tired, the doctor has to mentally run down a diagnostic tree of 100 possibilities.
Right. Depression, thyroid issues, sleep apnea, anemia.
Exactly. But suppose a patient has used an independent platform. They walk in and say, I'm experiencing profound fatigue that sleep doesn't resolve. I've noticed persistent bilateral edema in my ankles for 3 weeks, and I know I have a family history of hypertension. Could we run a comprehensive metabolic panel to check my kidney function?
You basically just handed the doctor the exact puzzle pieces they need, right side up.
You have.
You aren't diagnosing yourself. You're giving them high-quality data to
Yeah.
make their diagnosis faster. I like to think of it like hiring a general contractor to build a custom house.
Oh, that's a good analogy.
Right. Like, you don't need to know how to calculate the load-bearing physics of the roof truss.
Yeah.
That is the architect and the builder's job, the medical expertise. But if you don't know the difference between drywall and plywood, you won't know what questions to ask when the materials invoice arrives. You won't know if they're cutting corners.
That's a highly functional analogy. And if you aren't asking those structural questions, you might end up living in an unsafe home. Which leads seamlessly into the third and perhaps most vital pillar discussed in our source material.
Medication safety.
Medication safety. Because if we connect this to the bigger picture, all the patient education in the world won't matter if your daily habits are quietly destroying the very organ you are trying to protect.
Right. Our source material explicitly states that one of the main reasons platforms like iMedix exist is because people often misunderstand medication risks. This feels like the crux of the entire public health dilemma surrounding silent diseases. Why do we misunderstand medication risks so fundamentally? We have warning labels, we have pharmacists, we have doctors. Where's the breakdown happening?
The breakdown happens at the intersection of statistical literacy and the psychological framing of risk. Human cognition did not evolve to intuitively grasp probability.
We're pretty bad at math instinctively.
Very bad. If a doctor tells a patient there is a 1 in 1,000 chance of a severe drug-induced kidney injury, the human brain struggles to weigh that accurately. An anxious patient fixates on the 1 and assumes it is inevitable, while an optimistic patient looks at the 999 and behaves recklessly, assuming they're invincible.
And the medical establishment often uses terminology that accidentally obfuscates the reality. I'm thinking about the difference between relative risk and absolute risk. I see this in drug commercials constantly, like reduces your risk of a cardiac event by 50%.
That is the classic example of obfuscation. Let's say you have a baseline risk of developing a specific renal complication, and statistically 2 out of 100 people with your profile will get it.
Correct.
Your absolute risk is 2%. A pharmaceutical company develops a drug that lowers that risk so that only 1 out of 100 people get it.
So it dropped from 2% to 1%.
Right. The drug has reduced your absolute risk by a mere 1%, but mathematically going from 2 to 1 is a 50% reduction in relative risk.
Oh, wow. So the marketing materials will scream 50% reduction, while the actual clinical benefit to the individual is incredibly marginal.
Exactly, which totally skews a patient's decision-making process. They might accept a drug with heavy side effects because they think they're getting a massive 50% shield, when really they are getting a 1% shield.
And this misunderstanding becomes actively dangerous when we talk about common over-the-counter medications and early silent kidney disease. Let's look at the specific journey of ibuprofen, an NSAI, non-steroidal anti-inflammatory drug.
Yes, NSAIDs like ibuprofen or naproxen are perhaps the greatest unrecognized threat to a vulnerable renal system.
Here's the scenario. I go for a long run on a Saturday, my knees are aching, and I open my medicine cabinet. I have a massive bottle of 500 ibuprofen pills that I bought at a warehouse club for $12. It was sitting on a pallet next to the bulk paper towels.
The setting matters psychologically.
Right. The psychological framing of that purchase tells my brain, this is a commodity, it is completely safe, it is practically candy. I take 3 pills without a second thought.
Yeah.
Walk me through the exact biological journey of that pill and what it does to the silent struggle happening in a kidney.
Let's trace it. You swallow the ibuprofen. It passes through your stomach, gets absorbed in the small intestine, and enters your bloodstream. The active mechanism of an NSAID is to inhibit specific enzymes called cyclooxygenases, or COX enzymes.
Okay.
These enzymes are responsible for producing prostaglandins.
And prostaglandins are the lipid compounds that promote inflammation, pain, and fever. So by stopping them, my knee stops hurting.
Correct. But prostaglandins do not solely exist to cause pain. In the kidneys, specific prostaglandins act as essential vasodilators.
Vasodilators, meaning they keep blood vessels open.
Exactly. They keep the afferent arteriole, the tiny blood vessel that feeds blood into the glomerulus filter, wide open. They ensure a steady, robust flow of blood into the nephron, regardless of what the rest of your blood pressure is doing.
Oh, I see where this is going. So when the ibuprofen blocks the prostaglandins to fix my knee, it also blocks the prostaglandins in my kidney.
Yes. The afferent arteriole loses its chemical signal to stay dilated, so it constricts. The blood flow into the kidney plummets.
Wow.
Now, if you are a perfectly healthy 25-year-old who is well hydrated, your kidneys can usually handle that temporary drop in flow. But suppose you have early-stage silent chronic kidney disease.
Your remaining nephrons are already hyperfiltrating.
Right. They're already stressed, already demanding maximum blood flow just to keep you alive. When you introduce an NSAID and constrict that vital blood supply, you induce ischemic injury. You are literally choking the working nephrons of oxygen.
So a drug I bought next to the paper towels is suffocating an organ that is already failing. And what makes this so terrifying is combining it with the major risk factors for kidney disease.
The source material demands we look at why people are vulnerable in the first place. Diabetes and hypertension are the two undisputed heavyweights here, correct? By a massive margin, yes. And both of those conditions are fundamentally vascular diseases. They systematically destroy the delicate plumbing of the kidneys long before a patient realizes it.
Let's break down diabetes first. I've often heard people use a metaphor that high blood sugar acts like microscopic shards of glass in your bloodstream, cutting up the inside of your vessels. Is that biologically accurate?
It's a vivid image, but it's biologically incorrect. And it kind of misses the true insidious nature of the damage. Sugar molecules aren't sharp. The actual mechanism is called glycation, specifically non-enzymatic glycosylation.
Okay, unpack that for us. What does glycation actually do to the blood vessels?
When blood glucose levels remain chronically high, those excess sugar molecules physically attach themselves to the proteins and lipids that make up the walls of your blood vessels.
They just stick to them.
Yes, and this creates what we call advanced glycation end products, or AGs. These AGs cause the normally flexible, resilient proteins in the vessel walls to cross-link and become stiff.
So instead of a flexible rubber hose, the blood vessel turns into a rigid, brittle lead pipe.
Precisely. In the glomerulus, that delicate microscopic sieve, this stiffening is catastrophic. The blood vessels thicken, they become abnormally leaky, and eventually the entire filtering tuft collapses and scars over. It's a condition called diabetic nephropathy.
And then you add hypertension, high blood pressure to the mix.
Right. Hypertension acts as a mechanical battering ram. The heart is pumping blood at an abnormally high pressure. When that high-pressure wave hits the tiny, delicate arterioles of the kidney, it causes sheer physical trauma to the vessel walls.
So they get damaged from the force.
Yes. And to protect themselves from blowing out, the vessels thicken their muscular walls, a process called hyaline arteriolosclerosis.
Which narrows the opening of the vessel even further, reducing blood flow to the filter, which again causes the nephron to die off.
Exactly. Now, combine all of this. You have a patient with mild unmanaged hypertension who is slightly pre-diabetic. Their renal vessels are already stiffening and narrowing. Their nephrons are fighting a silent war, hyperfiltrating to keep up.
Okay.
Then they get a bad backache and take high doses of ibuprofen for a week, constricting whatever blood flow they had left. Because they misunderstood the risk of an over-the-counter pill, they pushed themselves from early-stage silent disease into acute kidney injury.
That is the ultimate public health crisis.
Mm-hmm.
It is an architecture of failure. And honestly, the way the medical industry currently communicates these risks is completely broken. Think about the standard experience of picking up a new prescription.
Oh, it's a mess.
The pharmacist hands you a bag stapled to a folded piece of paper with microscopic, densely packed text. It lists 400 possible side effects, ranging from mild dry mouth to spontaneous liver failure with absolutely no contextual weighting. Does providing that massive volume of raw information actually cause people to understand less.
Yeah.
It absolutely does. It causes profound cognitive fatigue. It's a phenomenon well documented in human factors engineering. When every possible outcome, no matter how statistically improbable, is presented with the same visual weight, the brain simply tunes it all out. It becomes white noise.
It's the exact same psychological mechanism as reading the terms and conditions on a new software update for your phone. You know you're supposed to read the 50 pages of legal jargon, but you don't. You just scroll rapidly to the bottom and click accept because you want to use the app.
Exactly the same.
We treat medication warning labels the identical way. But that language isn't designed for human comprehension or patient safety. It is designed entirely for the legal liability protection of the pharmaceutical manufacturer.
And that failure of communication is where the sense of clinical urgency gets lost. Because patients tune out the warning labels, they lose the ability to differentiate between a side effect they can casually mention at their next annual physical and a severe symptom that requires immediate life-saving intervention.
That is a critical distinction we need to make clear right now. In the context of everything we've discussed, the edema, the fatigue, the electrolytes, what crosses the line from I should schedule an appointment next month to I need to go to the emergency room right now.
Urgent evaluation is mandatory when the kidney's failure to regulate fluid and electrolytes becomes acutely life-threatening. Let's look at fluid first.
Okay.
If that edema we discussed earlier stops pooling in your ankles and begins accumulating in your lungs, a condition called pulmonary edema, it is an immediate crisis.
What does pulmonary edema actually feel like to the patient?
It manifests as severe, sudden shortness of breath, particularly when lying down. Patients often describe a sensation of suffocating or drowning while fully awake.
Oh my God.
They might start coughing up frothy, pink-tinged sputum. Your lungs are literally filling with the fluid your kidneys failed to excrete. That is a 911 emergency.
Drowning from the inside out. That's terrifying. And what about the electrolytes? We talked about calcium and phosphorus causing the itching. What is the acute danger there?
The most immediate lethal threat is hyperkalemia, which is critically high potassium.
Potassium. The stuff in bananas. How does that become lethal?
Well, potassium is fundamentally responsible for regulating the resting membrane potential of your cells. It's the electrical charge. Inside your cells, potassium levels are very high. Outside in the blood, they're very low.
Right.
This difference in electrical charge is what allows nerve impulses to fire and muscles to contract.
Including the most important muscle in the body, the heart.
Exactly. When the kidneys fail to excrete excess potassium, it builds up rapidly in the bloodstream. The electrical gradient between the inside and outside of the cardiac muscle cells is just destroyed. The heart cells can't reset their electrical charge after a heartbeat.
So the heart's electrical system basically shorts out.
Yes. Severe hyperkalemia causes muscle weakness, but more importantly, it causes cardiac arrhythmias. The heart rhythm becomes chaotic. You might feel severe palpitations, chest pain, or a fluttering sensation. If it isn't treated immediately to drive the potassium back into the cells, it leads to sudden cardiac arrest.
Okay, so if the stakes are as incredibly high as sudden cardiac death or fluid filling the lungs, and the standard method of communicating risk, the microscopic warning label, is failing miserably, what is the alternative? How do independent platforms like iMedix actually solve this crisis of communication?
They solve it through deliberate database architecture. Our source material points specifically to the iMedix drug database and educational resources. We have to analyze what makes a dedicated drug database functionally superior to a standard web search.
Because my instinct is just to Google ibuprofen side effects. How does the architecture of a database change that interaction?
Well, a search engine algorithm retrieves isolated, fragmented web pages based on keyword density, popularity, and SEO manipulation. A structured drug database is built on relational architecture.
Relational architecture, what does that mean in this context?
It maps the pharmacological reality of the drug, how it's metabolized, where it's excreted against specific biological conditions. It allows you to cross-reference the data.
Give me a tangible example. How does a patient use that relational architecture?
Let's assume you've been proactive. You went to your doctor, got your blood work done, and you know you have early-stage asymptomatic kidney disease. You go to an independent drug database and look up a new medication your dentist prescribed.
Okay.
The database doesn't just hand you a list of 400 side effects. It reads the metabolic pathway of the drug. It will prominently flag, this medication is primarily cleared by the kidneys, it is contraindicated or requires significant dosage adjustment in patients with reduced eGFR. It instantly brings order and clinical relevance to the chaos of the warning label.
Let's pause right there,
Oh,
because you just dropped the acronym that is the ultimate key to unlocking the entire silent struggle.
yeah.
EGFR, estimated glomerular filtration rate.
Yes. If we establish that active vigilance and laboratory testing are the only ways to catch the silent disease before the catastrophic symptoms appear, then EGFR and serum creatinine are your primary radar systems.
But again, this goes back to the educational resources the platform provides. Data without biological context is useless. I log into my patient portal, I look at my annual metabolic panel, and it just says creatinine 1.2 and EGFR 65.
Right, just no numbers.
To the average person, those are just random numbers on a screen.
Yeah.
The educational resources have to provide the narrative.
They do. A good platform explains that creatinine is a natural waste product generated by the normal wear and tear on your muscles. Because your muscle mass stays relatively constant day to day, your blood creatinine levels should stay constant, provided your kidneys are filtering it out effectively.
So if my blood creatinine number starts creeping up over the years, it isn't because I'm suddenly building massive amounts of muscle. It's because my renal filters are failing to clear the waste.
Precisely. And that creatinine number, along with your age, biological sex, and body size, is plugged into a mathematical formula to calculate your EGFR.
And EGFR isn't just a generic percentage score, is it? I've seen it described as a measure of flow.
It is exactly a measure of flow. It estimates how many milliliters of blood your glomeruli are filtering per minute, adjusted for standard body surface area.
Okay.
A normal, healthy EGFR is typically 90 or higher, meaning 90 milliliters per minute are being cleaned. When that number drops to 60, you are in stage 3 kidney disease. When it drops to 15, you are in kidney failure.
This raises an important question about the design of these platforms.
Yeah.
How do we ensure that databases explaining EGFR and creatinine remain accessible to the average patient? How do developers avoid just replicating the confusing medical jargon of the warning labels they are trying to replace?
It fundamentally requires a commitment to patient-centric layered design. Information must be progressive. You don't hit the patient with the complex biochemistry of COX enzyme inhibition immediately.
Right. You give me the plain English, actionable takeaway at the top of the page. Do not take this medication if you have reduced kidney function.
Exactly.
Then, if I'm curious and want to understand the mechanism, provide a link that lets me click a level deeper to learn about prostaglandins and renal blood flow.
That layered approach transitions the patient from being a passive recipient of healthcare, someone who just opens their mouth and swallows whatever pill they are handed, to an active co-manager of their own biology.
Co-management. That is the perfect term. You're partnering with your physician, but you're carrying your own weight. You are using your laboratory testing as your personal biological baseline and using independent platforms as your pharmacological map. And this is so deeply relevant to you, the listener, right now in this exact moment.
Because the vulnerability is universal.
Exactly. Even if you are sitting there listening to this thinking, my kidneys are fine, I run 3 miles a day, I don't have diabetes, my blood pressure is perfect.
It still matters.
Having access to a reliable, independent database and understanding how to read your routine metabolic panels is a lifelong critical skill. It is crucial for every time you catch a winter cold and want to take a heavy decongestant. It's crucial every time you get a migraine, every time you see a targeted ad for a new, unregulated wellness supplement and wonder how your liver and kidneys will actually process those exotic herbs.
They process everything.
Your kidneys process almost everything that enters your bloodstream. Protecting their silent work is a daily task.
It requires replacing the dangerous silence of the biological disease with the clarity of verified, structured information.
So let's synthesize the journey we've taken today. We started by confronting the chilling, almost invisible reality of the silent struggle of early kidney disease. We looked at the sheer biological resilience of the nephron, exploring how the cycle of hyperfiltration allows an organ to lose massive amounts of function while you feel completely fine.
Masking the damage until the subtle systemic signs finally break through.
Right. We examine the mechanics of those signs, how hydrostatic pressure causes edema, how the loss of erythropoietin starves the brain of oxygen, how calcium phosphate imbalances cause agonizing itching, and how damaged podocytes leak protein into the urine, giving you that foamy look.
We also discovered that combating a disease that hides in the shadows requires bright, clear, and absolutely independent information.
Yes. We explored the deep flaws of relying on commercial search engines, SEO spam, and AI hallucinations for medical truth.
And we looked at how platforms like iMedix tackle the structural problem of misunderstood medication risks through the relational architecture of drug databases. We saw how the human brain fails to process absolute versus relative risk, and how warning labels function as legal shields rather than educational tools.
And we established that active vigilance, specifically routine laboratory testing of your creatinine and your eGFR, is the only way to monitor the silent workings of your own body. It's the data that allows you to ask precise, structured treatment questions and avoid inadvertently destroying your own filters with everyday over-the-counter medications like ibuprofen.
Knowledge is only a protective shield if it is comprehensively understood and consistently applied.
Which brings it all back to you. Your health, your physical biology, is the ultimate personal asset. Navigating its complexity shouldn't feel like wandering through a dark, silent maze where you're constantly bumping into walls you can't see.
No, it shouldn't.
Finding your trusted, independent sources of medical truth is quite literally just as important as finding a highly skilled doctor. They are two halves of the same survival strategy. So as we wrap up this deep dive, I want to leave you with a final thought to mull over. Something that builds on everything we've unpacked today regarding the psychology of risk, the architecture of information, and the biological resilience of your body.
It's an important question to ask.
If the silent struggle of kidney disease is so heavily exacerbated by our widespread societal misunderstanding of medication risks, it forces us to ask a much broader question. Is the real silent illness in our modern world actually our inability to effectively communicate scientific truth? Think about the factory analogy we used at the beginning. We want the manager to know exactly what is happening on the floor. But chronic health is a murky, complex, constantly negotiated contract.
Very much so.
So the next time you pick up a new prescription or buy a bottle of painkillers from a warehouse club, ask yourself a hard question. Are you truly consenting to the biological treatment, deeply understanding the invisible risks to your silent organs? Or are you just blindly clicking accept on the terms and conditions of your own body?